Hello, everyone. I'm Dr. Manju George, the Scientific Director of Paltown Development Foundation, the nonprofit that supports Colontown. Today, we have the Colorectal Cancer Conference Roundup. The format for this doc talk is slightly different. We have two expert clinicians, Dr. Smitha Krishnamurthi and Dr. Cathy Eng. So we'll start with Dr. Krishnamurthi's presentation.
Hi, I'm Smitha Krishnamurthi. I'm a medical oncologist specializing in the care of patients with gastrointestinal cancers and to conduct clinical research. And thank you, Manju, for this wonderful opportunity to discuss updates in clinical trials for patients with colorectal cancer. As some background, I started out actually focused on breast cancer when I was a fellow long ago at Hopkins. But then in my first faculty position, they needed somebody to focus more on GI cancer. So I had a 70-30 split between GI and breast. And then soon after, we got some exciting drugs, Bevacizumab and cetuximab, and I decided I wanted to focus entirely on GI cancers. So I made that transition, and I've never looked back. I've enjoyed also working with phase 1 studies, which are so exciting. And I've held administrative roles as the medical director of the clinical trials unit and clinical research office for our cancer center. But now in my position at Cleveland Clinic, I'm really thrilled to be focused mostly on opening clinical trials for patients with colorectal cancer, in addition to patient care. I view it as my mission to try my best to improve outcomes for patients with colorectal cancer by providing the best care that I can, which includes clinical trials. So I'm excited to increase our portfolio of clinical trials and very excited to discuss these updates with my dear friend, Dr. Cathy Eng, and with you, Dr. Manju George. So thank you so much for having me.
Dr. Krishnamurthi, so glad to have you with us.
Thank you, Manju. Thank you so much for this invitation. I've been so excited about this. Really looking forward to this chance to discuss these very interesting studies. And I want to keep this really informal. So I don't want to do too much talking. I'm going to make sure we have time for any questions. The first study was presented at ASCO by Dr. Jean T, and she subsequently published in New England Journal. This is a study of, it's called a dynamic study. It was using circulating tumor DNA to guide treatment for patients with stage 2 colon cancer. So, you know, what it was is the figure shows patients had stage 2 disease, T3 or T4 tumors, node negative, and they were randomized 2-to-1 to ctDNA guided management or standard management. So they had their blood drawn for plasma circulating tumor DNA 4 and 7 weeks after surgery. And then it takes some time to get the results. So they got the results like 8 to 10 weeks after surgery. So they did, that group started treatment later than those assigned to standard management who had their blood drawn, but they didn't get the results. I think they will probably get the results at a later date. Then the circulating tumor DNA group, those patients who had no detectable tumor DNA in their blood were assigned to observation, and those who had detectable tumor DNA were assigned to chemotherapy. And it could be oxaliplatin-based, like Folfox or Capox, or just a single agent like capecitabine alone. And a standard management group had their treatment based on, you know, clinical pathologic features. You know, they could get chemo or observation. And, you know, what they found was that their primary endpoint was the 2-year recurrence-free survival. And there really was no difference between the group that had their treatment based on circulating tumor DNA and the group with standard management. This was like a non-inferiority study. So it certainly did not appear that using ctDNA was inferior. Then they found that they had fewer patients received adjuvant chemotherapy in the group with the circulating tumor DNA-based management. So it's 15% of those patients got chemo versus 28% in the standard group. But, you know, what's interesting is that of the patients who got the chemo in the ctDNA group, 62% got oxaliplatin-based chemo, whereas those in the standard management, only 10% of them did. So when you do the math, it's actually you're twice as likely to get oxaliplatin-based chemo with the ctDNA guided management. And then they also showed that among people who had in the ctDNA guided group, what was the recurrence-free survival at 3 years if you're ctDNA negative or positive? And you see the ctDNA negative patients had excellent outcomes, with 92.5% not having a recurrence at 3 years. It was not as good in those who had detectable DNA, but 86%. And of course, they all got chemo. So, conclusions from this, that the ctDNA guided therapy decreased use of adjuvant chemotherapy without increasing the recurrence rate, although more of those patients received oxaliplatin. And those patients who were ctDNA positive, I think they appear to benefit from chemotherapy, because we do know that from other studies that the risk of recurrence is quite high when patients have detectable circulating tumor DNA. And this study confirmed what we've seen in other studies, that if there's no detectable ctDNA, the risk appears to be very low for recurrence. So I'll stop there and see if anyone wants to comment, or are there any questions?
Yeah. Dr. Eng, thank you for joining.
My name is Dr. Cathy Eng from Vanderbilt Ingram Cancer Center, and I'm delighted to participate today in the colorectal cancer roundup. Thank you, Manju George, for inviting me. It's my sincere pleasure to have this roundtable discussion with my friend and colleague, Dr. Smitha Krishnamurthi. We really hope to enlighten all of you about potential treatment options following this year's meetings, as well as what is on the horizon for our patient population. Once again, we really hope that all of you learn from our perspective regarding both early and metastatic colorectal carcinoma, and we hope to provide you additional treatment options, as well as maybe consider future clinical designs for clinical trials. So thank you once again for inviting me. It's my sincere pleasure, and if you have any questions, please feel free to reach out to me. I want to say that I do appear to be a bit more casual today, and that is because I want to acknowledge one of my best friends who unfortunately passed away from colorectal cancer, and I am wearing this Super J t-shirt on her behalf. So thank you for allowing me to do so.
I was thinking that maybe you can start with the discussion on dynamic too. So Dr. Eng, what do you think about the study?
Yeah, so the study obviously is one of the largest studies we have. I have to congratulate Dr. T, right? She was really the first woman, not only a woman, but first investigator that really took the opportunity to highlight the potential benefit from one of her earlier studies. Granted, that was a smaller study. This study provides more information about the potential utility, especially for our stage 2 patients, where for decades now, it has been very ambiguous as to what should be the standard of care. And all the guidelines say, just have a discussion with the patient, and you and the patient should decide, which, it's very hard as a patient to make those type of decisions. So I'm glad that she proceeded to evaluate the role of circulating tumor DNA. As you know, there's many different platforms, and the company she was working with obviously really supported this effort. I would say that it demonstrates, obviously, there's potential benefit of making decisions based upon the circulating tumor DNA, and hopefully reducing the toxicity, because then patients won't necessarily be exposed to FOLFOX unless we really believe it's necessary. I do think it's very interesting that if you look at the data, we don't know the duration of adjuvant chemotherapy. It's not mentioned. It wasn't mentioned in the presentation, and I couldn't find it in the publication. Who knows, maybe it's in the supplement. But I do find interesting that on the control arm, they only gave them Xeloda or 5-FU. So it is informative, but I think it provides further support for our ongoing COBRA and CIRCULATE-US trial for both stage 2 and stage 3 patients.
Yeah, that sounds like a good summary. Dr. Krishnamurthi, do you have anything to add?
I totally agree that the COBRA trial standardizes the treatment, so everybody's going to get FOLFOX or CAPOX in the ctDNA guided arm if they're having detectable ctDNA. So I think that it is a much larger study, so I think the results will be more definitive. It's like seeking to enroll, I think, like 1,400 patients, and circulate 1,900. So these are really large, going to be definitive trials. So
And I heard that Dr. T is going to present some data at ESMO regarding where the ctDNA positive or the people who had recurrence, where the sites of recurrence, something like that. So that'd be nice to know. Okay, questions from the group?
Please don't be shy. We prefer questions.
Yeah, exactly.
Okay, we can go to the next one. And so if you have questions and if you are hesitant to ask them, you can type them in chat and then we can look at them towards the end of the meeting or the session.
Switching gears then, other very exciting study presented at ASCO was this trial by Dr. Andrea Sursek and colleagues at Memorial Sloan Kettering, in which they treated patients with deficient mismatch repair, MSI-H rectal cancer with the PD-1 antibody dostarlimab. And of course, this was based on the known activity of immunotherapy for patients with deficient mismatch repair cancers in the metastatic setting. And there had also been the niche study demonstrating impressive activity in the neoadjuvant setting for colon cancer. This study took 30 patients with stage 2 and 3 rectal cancer, and kudos to Dr. Sursek and colleagues for doing this because this is a rare population. We've looked at our own population at Cleveland Clinic. It's only 3% of our patients with stage 2 and 3 rectal cancer, but they were able to enroll 30 patients and they treated them with this IV dostarlimab once every 3 weeks for 6 months with the idea that patients would go on to get like the standard chemo, radiation, and surgery. But then what they found, and they had 12 patients evaluable at the time of the presentation, was that 12 out of 12 had a complete clinical response. So no more tumor on digital rectal exam, endoscopy, MRI. They even took biopsies, no viable tumor. PET scans were part of the study and they had normalized. And so these patients remain on observation and are avoiding the toxicities of radiation and surgery. They did find that almost 2/3, 57% had germline mutation, which we'd expect. Most of these patients will have Lynch syndrome. The treatment was pretty well tolerated with, just they reported grade 1 and 2 adverse events. Nobody had even like a grade 3 toxicity. So it certainly looks more tolerable than our usual approach of chemo radiation. And yeah, I think that's it for what I had for this study. So
yeah.
Don't forget, we have a national trial ongoing in the United States, as well as your own trial at your own institution.
Yes, exactly. Thanks, Kathy. You and Kristen Siambo are leading the ECOG study. Do you want to talk about that?
Yeah, so this is, Kristen and I were just talking about it because it's kind of hilarious. I wrote this trial for Nivo-Ipi and MSI-H rectal patients in 2018, and people thought I was crazy, except for of course, my colleagues at MD Anderson. And I said we should have sphincter preservation as a primary endpoint, and everyone said no. And then I said, they wanted a response rate. We chose a response rate of 50%. And they said, oh, you're being overly ambitious.
Oh my gosh.
Yeah, exactly. So kudos definitely to Andrea Sursek for being able to open that up at a single institution. I wanted to take it to a much bigger level, national level, and that's why we opened it up through ECOG. And I brought it with me to Vanderbilt, and my former colleagues at MD Anderson were kind enough to let me bring this concept as our own concept here at Vanderbilt, just because it was something that I wrote and created. And so Kristen Siamberg, who's our rising star at Vanderbilt, is leading this effort. So currently, as written, it's Nivo-Ipi for 2 months, then short course radiation therapy. It's ECOG-2201, followed by more Nivo-Ipi for 2 months, and then the consideration of surgical resection. An amendment is currently pending at this time, so we're moving all the immunotherapy to 4 months upfront, because obviously the dostarlimab was provided for 6 months, and we honestly don't know, is 6 months really necessary? And we know there's potential toxicities associated with immunotherapy. So we are going to stick to our 4-month interval, and then with Dr. Das, who's our other co-chair, who's also the chair for the rectal anal task force, is going to recommend radiation short course if there is still some concern. And then obviously the consideration of sphincter preservation as long as clinically indicated and a complete response. So we hope that that will be the case, and that will be that's an opportunity for individuals that can't fly to Memorial Sloan Kettering to participate in their trial locally, because it's available at over 60 sites nationally to date. And obviously there's a lot of controversy still regarding single agent immune checkpoint inhibition versus a doublet immune checkpoint or immunotherapy, as we can see for our metastatic setting, just because there appear to be a higher response with doublet therapy. But it's hard to say. The dostarlimab trial is definitely very intriguing, but it does still have short-term follow-up, and it was only a single site. So hopefully it'll get replicated once it, if it gets expanded further, and hopefully we will have similar findings as well.
Yeah, okay. So we have in Colontown University, we have doc talks by Dr. Sirsak, as well as Dr. Siombor and Dr. T. So we have all these talks that have been discussed here. You can find more information there. And then to both of you, the question, when do you think immunotherapy will be standard of care for early stage rectal cancer patients? What is do we need a randomized controlled trial for that?
I don't know if we, Smitha, you can go ahead. I'm sorry to interject.
Oh yeah, no problem. I don't think we're going to have a randomized trial, because it's hard to do in such a rare population. And I think, though, as Cathy pointed out, there are still so many questions, like the duration of immunotherapy, doublet versus single agent. Our study at Cleveland Clinic, it was written as chemoradiation with pembrolizumab. We are considering revising that, making the radiation, if patients don't have a complete response. But we don't know, will the duration of response be longer if people get radiation? So I think the studies are really still critical. But to your point, Manju, I feel, honestly, if I have a patient with deficient mismatch repair rectal cancer and I didn't have a trial available, like the ECOG study was not nearby, or that is at 60 sites, which is terrific. I would be looking into, could we get the immunotherapy for the patients off, get it approved through their insurance. I think we need these studies to advance the field, to learn what's the right approach. But I understand when somebody has this diagnosis now, seeing this data, that they shouldn't get chemo. I do feel like they don't respond well to neoadjuvant chemotherapy that was shown in Foxtrot.
But should they go straight to surgery, right? Because that would be a standard of care.
Yeah, but I think with young patients, they want to avoid surgery at any cost. So getting immunotherapy up front would seem like a viable option now, right? Now that the studies are showing that, you can avoid surgery most likely.
Yeah, well, that's what we hope. Right. But I think it should be, and Smitha can chime in on this. It's very clear from our metastatic patients, there's fibrosis. There's significant scar tissue formation created by the immunotherapy itself. So it's found intraoperatively on our patients. So, it'll be interesting once again to see long-term follow-up. Do we need to have another trial to validate the findings at Memorial Sloan Kettering? Once again, I'm always hesitant when I see data from a single institution.
Yeah. Okay. So there's a question.
Nothing against Dr. Sirsak. Love Dr. Sirsak. She's a friend of mine.
Yeah, I think that's a question about the NICE trial. So they did it with colon cancer, right? And they had great responses too. Yeah. So the question is about whether it'll be a standard of care, or would this be an option, immunotherapy be an option for, stage 3 MSI high colon cancer patients?
I think that's a little harder because, they don't have the same morbidity as the rectal cancer treatment. It's just surgery. The bowel pattern afterwards is, usually not too far from normal, not like patients with low anterior resection syndrome. We don't have the same fertility issues. So I really would be in favor, and of course it's more common in colon cancer than rectal. So, we can do these studies. I would be much more in favor of a clinical trial and standard immunotherapy there.
Okay. We can go to the next one. Thank you for the great discussion.
Sure, thank you. All right, so
please keep the questions coming in chat.
And so actually this, is a good segue, because the next study I wanted to discuss that was updated at ASCO was the new study, which was conducted by Miriam Chalabi at Netherlands Cancer Institute. And, kudos to her for this design, because she enrolled patients not only with deficient mismatch repair colon cancer, but also proficient mismatch repair colon cancer. And the patients with the deficient mismatch repair disease were assigned to Ipi-Nivo, ipilimumab 1 dose, nivolumab 2 doses before going to surgery. And they enrolled patients like stage 1 to 3 cancers. With the proficient mismatch repair, MSS, the patients had the same treatment with or without celecoxib, Celebrex, 200 milligrams daily, and also then went on to surgery. They had, 10% of the patients were stage 1. Most of the patients were stage 3. They did have 13% had a severe toxicity, like immune toxicity, rash, colitis, and then lab abnormalities. But everyone got to surgery. And then this was the update that she showed is so impressive in the patients with the MSI high cancers. They had almost everybody had a major pathologic response, meaning like less than 10% living tumor left. You'll see not everybody had a complete response, so like tying into Dr. Sursek's study, for rectal cancer. Of course, her treatment there was 6 months. This was literally just, 2 doses of immunotherapy. So not everybody had a complete path response, but it was very short treatment. And nobody was a non-responder. And they did, it's a very small data set. They showed like the patients who had Lynch syndrome, most of them had a CR, whereas in the patients who did not have Lynch syndrome, it appeared to be less common, but we certainly need more data to see if this is really going to be the case. And then nobody had recurred. Their median follow-up was 32 months. And, I just had one more slide on this, which is that for our patients, the vast majority of patients have MSS colon cancer, or proficient mismatch repair. The first study I'm aware of that boldly treated these patients with immunotherapy was Dr. Avallone's study in Naples, where he treated with nivolumab 2 doses before surgery. And out of 18 patients, 1 had a complete response and 1 had 90% regression. So that's the first sign of activity. And then you have this niche study, again, very bold to treat these patients. They had 7 out of 31 of the patients with MSS or proficient mismatch repair disease had a major pathologic response, and that's what's shown here. And they found that the tumors that had CD8 and PD1 expressing T cells were predictive of response. Of course, we need more data on this to see, is this really valid? How can we identify who is likely to benefit? But thought that was very interesting for both sets of patients.
Yeah, we'll see if anybody has any questions. The only question I had was like, when compared to the rectal cancer studies, even after the end of treatment, normally, there is some time to see whether there is a response or not, right? In these cases, I think after treatment with the immunotherapy, they went directly to surgery. So there wasn't that lag phase to see whether there was continuing response, right? So I was wondering whether those patients which had the bars were almost reaching the bottom, if we had waited, would we be able to see a complete response?
Yeah, I think that's a great point. And I think probably there would have been more patients with a complete response with the longer duration of treatment, because this was very short.
Yeah. Dr. Eng, do you have any comments? Or yeah, there's one question. I can just go to that one. What is the threshold for CD8 T cell positivity? Like, is there something, did they use Immunoscore in this one?
That's a great question. Speaking with Dr. Chalabi, she said that Immunoscore is actually her inspiration for the study, recognizing that some, about 20% of early stage colon cancers do have this immune infiltrate. Immunoscore is looking at CD3 and CD8 cells. But I don't think they used Immunoscore in the study, but they were looking for CD3 and CD8. She told me that they did not replicate that. So they didn't find that patients with a high CD3 and CD8 infiltration were the ones who responded of the MSS patients. I actually don't recall the threshold for positivity of CD8 and PD1, sorry. All right, so I think this is the last one that I wanted to discuss. I thought this was so interesting, and I congratulate these investigators in China who sought to study the effect of high-dose vitamin C, because we have so many of our patients are getting this, from practitioners in the community who specialize in these like naturopaths, and so this was based on old data, of course, from Linus Pauling, showing benefit to high-dose vitamin C. But this is now very recent data in patients with metastatic colon cancer. This is the study design down here. Everyone got FOLFOX and Bevacizumab, and then the randomization was to receive high-dose vitamin C, which was 1.5 grams per kilogram per day IV for 3 hours. Days 1 to 3 every 2 weeks. And Charlene Gill gave she gave the discussion at ESMO GI, but she also had to present the study because there was some technicality and the presenter was not available.
No, the presenter, there was a miscommunication because I was chairing the session. The presenter thought by doing a previous taping for something else, which was an interview, he thought that was his presentation. It was being videotaped.
Oh my God, that is so sad.
Yes.
But she did a phenomenal job, and she pointed out that this dose of high-dose vitamin C was like eating 2,000 oranges a day. So super high dose, 3 days in a row, every 2 weeks. They were looking at primary endpoint PFS. And they found in the intention to treat population, there was no difference in progression-free survival shown on the left and overall survival shown on the right. So of course that is disappointing. They did see more nausea and vomiting in the patients who received the high-dose vitamin C. And they had a pre-specified analysis in patients who had RAS mutations, and there did appear to be a benefit there in terms of the PFS, a very small difference, like 9.2 versus 7.8 months. It is like hypothesis generating. So, certainly that this warrants more study in patients with RAS mutations. And Dr. Manish Shah and colleagues at Cornell are conducting a study of high-dose vitamin C for patients with various types of RAS mutant cancers. And I believe there is like a infusion over like 5 days. So that'll be very interesting to see those results. But, I would advise my patients not to take vitamin C, going through all that hassle, the time.
Well, not high dose.
Yeah, not high dose, exactly.
Yeah. And Dr. Krishnamurthi, what is that pre-specified endpoint? How does that matter? Like, why did they have something like that?
Yeah, so I mean, I think it's better than a post hoc analysis where you didn't plan for this, and so the randomization may not be equivalent. Like you may not have data on everybody, and so you kind of lose the benefits of the randomization. This was a pre-specified analysis.
Okay. And Lindsay makes a point saying that it's very expensive for patients to do the vitamin C infusion. So that's another thing, if it's useless, then not waste their time and money on it. Yeah.
I think I love the question that you asked regarding pre-specified endpoints and post hoc analyses, right? I think it's really important for patients to understand that as well, because pre-specified endpoints are how we design our clinical trial and how we design the sample size and the power of the study. But as post hoc analyses, you'll see this a lot. Maybe they didn't fulfill the primary endpoint and they're trying to find something, put it incidentally.
Yeah. Dr. Eng, we lost you for a couple of seconds. So we didn't hear the last part, I think.
Oh, I was just saying that, post hoc analyses, it's because they see a hint of something else, or maybe they didn't fulfill their primary endpoint and they're trying to find some other signal.
Okay. I think, Dr. Eng, do you want to share your slides?
So I thought this was extremely important. I hope you share this. This is the SYNCHRONOUS study, which did not get a lot of press, but it's extremely important for those that are being treated in the community setting. So we always hear about, if you have metastatic disease, should I have my primary tumor resected? Is this really necessary? Because there was data previously in Europe which suggested that it would be beneficial for patients, and it's always been a point of discussion here in the United States, where we commonly do not resect the primary tumor unless the patient is having symptoms of bleeding or potential risk of obstruction, and obviously in the setting of perforation. This trial took 10 years to complete because they were unable to enroll. And so they actually, so it took 10 years to enroll, and it's really looking at patients that were subjected either to chemotherapy or to surgical resection followed by chemotherapy. And basically you'll notice in the investigational arm, 24% of patients went on to surgical resection and never received chemotherapy. And the primary endpoint here was really overall survival. And basically the key point is this: it is not necessary to remove your primary tumor unless there is a medical indication to do so. It does not improve your overall survival. And I would highly encourage you to make sure that everyone is aware of this study, because I see this too often in the community where some patient is told they have to go urgently to surgery and they didn't have any symptoms and there was no evidence of obstruction. And this only delays treatment of their other disease, right? So if you go to surgery, you need a 4 to 8 week recovery time before you can initiate systemic chemotherapy, which unfortunately puts your other distant metastatic disease at risk for further progression.
Yes,
okay.
That's a great
I'm
point.
like, what is going on today? I usually don't have trouble.
Yeah, no worries. Now we can hear you well. So let's see if anybody has any comments, discussions. Dr. Krishnamurthi, do you get a lot of questions about this too, about removing the primary?
Yeah, I think it certainly comes up, and I completely agree with starting with chemo first, and congratulate these investigators for getting this done. There was a Japanese study as well, I think, that presented a year ago that enrolled patients with, I think, a better prognosis. They limited to like 1 to 3 metastases, but considered incurable as well, and had the same results, that there's no benefit to removing the primary if it's asymptomatic. So I think that's very important to make sure everyone knows.
Yeah, and then my only question would be like, what are the conditions where, the primary would need to be resected, like a bleeding tumor or something? Would they get radiation? Like what would be the difference, like a different course of treatment that would happen?
Yeah, I agree. If the tumor's bleeding, sometimes our colleagues in radiation oncology will even give just 1 fraction of radiation to control it, and then we can get on with chemo. Of course, an obstructing tumor may need to be resected, or the bowel might need to be diverted. That's primarily what I would envision requiring surgery first.
Yeah, I think there are 2 questions. We can go through them quickly. So this is from Annie. Right side of the colon has more immunogenic functions than left side. I've always wondered if there's a difference in survival rates between the right side and left side.
So, I mean, we don't really know exactly why the right side does not fare as well as the left side for untreated patients. We really don't have strong data in the refractory setting, but for newly diagnosed patients, we really don't know the exact etiology for MSI stable patients. That's why there's a lot of interest in microbiome work. But I don't think we know exactly what is accounting for this. Smitha, do you want to comment?
Yeah, I agree. We don't know, and it's an interesting question. I think the question is wondering if there's a difference in outcome with the primary intact, and that's an interesting question. I don't know the answer to that.
And also, like, isn't it this that like the right-sided tumors like grow into larger, larger sizes at diagnosis because they may be asymptomatic, and the left-sided ones, because they usually have bleeding or some other symptom, may be likely to be diagnosed more? Is that a factor too?
That could be a possibility. Sure, there are different symptoms at presentation. Sure, yeah, I mean that is definitely a possibility. But is a right-sided tumor definitively going to grow faster? No, not necessarily.
Okay,
we don't have any data to support that.
Okay, thank you. The next question really asks the key thing. It's the thing that, like, doesn't that imply that a stage 4 patient can't get to NED if no surgery? So I think that's why patients are like really wanting to have the primary removed, because then they believe that increases their chances to getting to NED. So do you want to address that?
So a stage 4 So any stage 4 patient that is being considered for surgical intervention for their sites of metastatic disease, whether it's liver or lung or ablation of those sites or stereotactic radiation therapy with curative intent, like the goal is to rid that person of that disease completely, then it is the job of their surgeon to also remove their primary tumor. Unless, of course, there's always a setting where the patient doesn't want it removed. I've seen that before too, because they have a low-lying rectal tumor and they don't want an APR, and it looks as if the tumor is responding well. I have seen that periodically. But for all of our surgical patients where our goal is to make them NED, yes, the primary tumor would be removed.
Yeah, I think the point of these studies is that, start with the chemo, because as Cathy showed, that data showed that, a significant percentage of patients otherwise won't get chemo, which is what they, really is going to help them live longer. But then, of course, if somebody had a dramatic response and their disease became resectable, like say they had, too many liver lesions, and then they became resectable, we would certainly want them to go for resection of their mets and primary tumor to help them live longer.
Okay. So for patients, then what's probably important to know is that maybe the response to chemo is a better indicator to know whether they'll get to resectability than the initial, like at diagnosis, whatever they say, right? So then the removal of the primary is not like, they don't have to consider that if they didn't have the primary removed at the get-go, their chance of getting to NED is affected, because unless they see the response, they won't know, right?
Exactly, yeah.
Correct. We just want to make sure that people do not feel pressured to go to surgical resection of the primary tumor. I mean, that's what I've seen in the community setting, where patients feel pressured even though they weren't having any symptoms because their doctor felt it was more appropriate to remove the primary tumor, even though it's not necessary to improve the survival of these patients. And in fact, as Smitha suggested, chemotherapy is the most important aspect in this setting.
Okay, thank you. We could go to the next study.
So the next study is actually, it was from the ASCO plenary session. So this is not new data necessarily for everyone, but I think it is important data. So we, as mentioned earlier, we know left-sided tumors fare better than right-sided tumors for survival in MSI stable, treatment-naive patients with metastatic disease. We also had data from previous trials, 2 big phase 3 trials in a post-hoc analysis, where it looked like the role of anti-EGFR therapy, so anti-epidermal growth factor therapy, such as PMAB and cetuximab, appear to fare better in patients versus just receiving bevacizumab. But unfortunately, those analyses were post-hoc, so not pre-planned. And so they did a pooled analysis, and it still suggested that it was in favor of anti-EGFR therapy. So this is the first trial to look at it in a prospective setting. So this is the study design. This is for all RAS wild type treatment-naive patients randomized in a 1-to-1 fashion to FOLFOX PMAB versus FOLFOX bevacizumab, which is a big standard of care, especially in the United States, whereas in Europe, they've been using PMAB for quite a while. Primary endpoint here was overall survival. So this study is a bit unique, and I want to point out some very small points. In this patient population, oddly, 60 to 66% had their primary tumor removed, which is not a standard of care in Europe or the United States. So the patient population was a little bit different in that setting. But for the primary endpoint, focused on left-sided tumors that were all RAS wild type that received PMAB, they had a higher survival, which was the primary endpoint, and that was the purpose of this study. And also because, as you can see here, the survival was 38 months, which is a median. I always kindly remind patients that's a median. There's always patients that exceed that median, because some patients then think that they're only going to live exactly 37.9 months, and that is not the case. It is a median. I think it is also important to note that this trial has not been published yet. There were patients that underwent surgical resection for their metastatic disease. We do not know any of the data from those patients yet and their outcomes. We also do not know what type of maintenance chemotherapy was provided in this patient population. But for left-sided tumors, you can consider FOLFOX plus PMAB if you're all RAS wild type, and this may result in improved overall survival. They did show this, which I think is important because the progression-free survival, so the time to tumor growth, was no different between the two arms, but there was a greater depth of response, which you can see in blue, for the investigational arm versus standard PMAB. So difference in baseline of 59.4 versus 43.6. And the response rate is 80% versus 69%. So left-sided tumors, better prognosis, all RAS wild type, there appeared to be a greater benefit with PMAB. So we still are missing some data, but clearly that could be a great option for patients. Let's talk, so I'm happy to take any questions.
Yeah, isn't this something that we already do here in the United States in general, or?
So it's not as well adopted because unfortunately patients don't like acne.
Okay.
Yeah, I find that even after this data came out, now I tell my patients there is a benefit to first-line panitumumab, though of course Cathy made great points about some data we still need to see. People are not that interested. In my few patients so far since ASCO that we've discussed this, people really like to avoid having that acneiform rash. So it's definitely, it's an option. We were in the US using Bevacizumab first line more commonly. So I think maybe we'll see over the next year that'll shift.
Yeah, and so related to that, what do you both advise your patients with regard to the acneiform lesions when they have with the EGFR inhibitors? What do you advise to take care of them?
Yeah, all my patients get educated up front, and I provide them medications immediately as soon as they start. Although they don't necessarily always listen, I specifically tell them to avoid the sun and to start taking the medications as soon as they start treatment. Some patients unfortunately wait until they develop the acne, and then they are miserable. And so I highly encourage patients, if they are on anti-EGFR therapy, to start their skincare treatment immediately. And so I recommend topical and oral antibiotics.
Okay. Is that the same that you do? Yeah.
I recommend the doxycycline. They start taking that 100 BID. Also, I recommend that just right from the get-go. We know that the rash typically, appears a median 8 days later. And I completely agree. It's much better to prevent it as much as we can than to deal with it after the fact. But I have had patients who then, if they don't develop the rash, they stop the antibiotics and then just start it up again if they need to, because it does appear that not everybody needs to be on it all the time.
Okay.
And the moisturizing is so important. I find especially with men, they're used to using like deodorant soaps, and they're not used to putting on like creams.
Totally.
Right? They're the hard ones.
Yeah, I think it's important. No one asked me this question. I'm quite surprised. If you look at the data though from the TRIBE trial with FOLFOXIRI plus Bevacizumab, right, and the all RAS wild type patient population, unfortunately, it's not powered specifically for left-sided tumors. The data also is very good.
I think Julie has a question about, if the no rash or the rash, how is it related to efficacy? Is there?
There's old data that suggests if you have a rash, you have better benefit of response. But the reality is the rash is so bad with PMAB because 99% of patients will get a rash versus the cetuximab, which is a little bit less. So, we're proactive to treat the rash now. So
yeah, and then
the rash is just like a kind of a biomarker of efficacy, but the efficacy, you don't have to have the rash to respond, meaning like by preventing the rash, we're not taking away from the response.
Okay. Yes, okay. I think that's, yes, please. Thank you for pointing that out. Some people may want to, they're probably wondering, why are we stopping the rash?
Yeah.
Yeah. Okay, we can continue because you have a couple of slides and then we'll get to the questions in the end.
So this is what you should not do. And I think this is extremely important to point out. So this is the triplet trial. So looking at, there was data from a phase 2 trial called VOLFI, VOLFI earlier, which suggested that FOLFOXIRI plus PMAB had a high response rate. And in fact, because of that, should you consider that as an option for your patients? So Dr. Cremolini did this phase 3 trial. Primary endpoint here was response rate, which is a little bit different than, once again, what we normally consider, but these are drugs already approved. So standard FOLFOX PMAB versus FOLFOXIRI PMAB, all RAS wild type. So of course, once again, the majority of patients will be left-sided tumors, treatment naive patients. Oh, I'm sorry, I should point this out. Oh, can I go back? Oh. Okay. This is for a maximum of 12 cycles, and then they do maintenance. Primary endpoint response rate, no difference. So left-sided tumors, no difference if you throw everything underneath the sun with FOLFOXIRI plus PMAB versus FOLFOX PMAB, and the R0 or resection rate with completely clean margins was also not statistically significant. And we don't have the overall survival results yet, but the progression-free survival also was no different. And I'm so glad to see this because I know some people were supportive of the phase 2 VOLFI study, and I was trying to tell everyone not to do that because they had 25% grade 3-4 diarrhea on that regimen. And as you can guess, this regimen obviously results in myelosuppression and extreme diarrhea and acne on top of it all. So just a couple slides of please do not receive FOLFOXIRI PMAB if you have a left-sided tumor.
Yeah. My only question there would be that, for example, like without the PMAB, for like BRAF mutated patients, we see that they get the FOLFOXIRI, right? Are there situations where you would suggest that getting a triplet is better than getting a doublet? Would you comment on that?
In all fairness, I give the triplet a lot. I utilize it to reduce tumor burden depending upon what my goals of therapy and depending upon the performance status of the young patient. I think it's really important to keep in mind that the TRIBE trial, which was the original FOLFOXIRI study, reported one of the highest 5-year overall survivals reported with prolonged follow-up. I mean, they had a 25% 5-year overall survival just with chemotherapy alone. And I think that's extremely important to note. It's not for everyone. I know, Smitha and I know this, Andrea is a good friend of ours, but they don't utilize FOLFOXIRI at MSK. They use a lot of FOLFOX. I think it's just a preference. I love FOLFIRI too, though. But, once again, I think it's just a matter of discussion with your patient and, what they are.
Okay. Yeah, I agree. I think the FOLFOXIRI, exactly as Cathy said, it's not for everybody, but for the patients who do not have the option of the anti-EGFR antibody, when we're looking for driving a higher response rate, like trying to get somebody to surgery, the patient with the right-sided tumor or left-sided with a RAS or BRAF mutation, if they can tolerate it, I would use the FOLFOXIRI. And, we give it for 3 months. So it's bad, but it's 6 doses of treatment. We get our maximum response around that time frame and then can go to maintenance. Or potentially to surgery.
Okay.
Someone actually had a great question. Can you mention it, Manju, about the acquired RAS mutation? So this is actually, I've brought this up quite a bit with our European colleagues. Once again, that once again favor PMAB as a frontline therapy. We know that there is a potential chance of acquired RAS mutations. So meaning you could have been RAS wild type and then suddenly you became RAS, develop a RAS mutation, which is acquired mutation with time. And then obviously there is a potential for re-challenge in the future, but that's a small subset of patients. Do we know what % of patients, if they're treated up, will definitely develop an acquired RAS mutation? Unfortunately, we don't have that kind of data. I presume with prolonged follow-up, a paradigm largest prospective trial, and because I know there's Dr. Yoshino is excellent, and I'm sure he has those correlatives cooking, but I was always concerned that could be a potential, just because we know that is a high potential for acquired RAS mutations. But once again, you have to look at your pluses and minuses, and we don't have anything set in stone regarding the percentage of patients that will develop an acquired RAS mutation.
Yeah. There's a question about like third line versus PMAP challenge or re-challenge.
I think so. The point, if whether a patient gets the EGFR antibody first line or second line, when they progress, they very well could have, mutations acquired in the RAS pathway. And then the data does seem to suggest you wait 6 to 8 months and could clear that. And there are reports now of responses with the re-challenge. So I think whether somebody gets it first line or second line, eventually they could try for the re-challenge down the road.
Mm-hmm.
Which means you have to get your circulating tumor DNA rechecked.
Yes.
Yeah. Actually, Kronos just came out a publication, I think today.
Yes.
It's actually Dr. Ilsen's, it's not his favorite study. I know that. At Memorial Sloan Kettering Cancer Center. I think it provides informative data, and there is further discussion about the CAVE trial, CAVE, from the European group, and whether or not they should expand that further as well. It was a small phase 2 study as well.
Yeah, I think we can go forward because we are running out of time.
So this is just this is a hot off the press update too regarding MOUNTAINEER. MOUNTAINEER basically was a phase 2 study, of tucatinib and trastuzumab for HER2 positive patients. I'll just show you the study design real quick. Once again, emphasizing the importance of asking your doctor, are you HER2 positive? Right, so really focusing on, there's early data suggests that you should be tested. There's benefit of therapy for using trastuzumab or Herceptin, as many of you may know of it, in refractory colorectal cancer patients. It's less than 4% of our patient population, but this study was looking at tucatinib and trastuzumab, basically with an expansion cohort, and then looking basically at single agent versus double therapy requiring 2 prior lines, pretty much standard. You must have failed FOLFIRI or FOLFOX before. And the response rate was 38% in this refractory patient population. This is one of the largest studies reported in HER2 positive patients. And it's also important for you to note that when we say HER2 positive, you either need to be HER2 positive 3+, very similar to breast cancer, although now the data in breast cancer is a little bit different. Historically, in breast cancer, you have to be staining 3+, or HER2 2+ and FISH positive. So it's a special staining that must confirm you are actually HER2. And that actually has relevance in colorectal cancer and response, because we know if you're HER2 positive 1+, you don't benefit from this type of therapy. This was basically the waterfall plot demonstrating the response. Patients with reduction in tumor, of the 80+ patients, 65% had some type of reduction in tumor burden, and there were some CRs. So this was a heavily pretreated patient population. And this was quite impressive. It was a strong progression-free survival, granted single arm study, of 8.2 months and overall survival of 24.1 months. So the median follow-up is also quite long. It's at least a little over 20 months. And so now there's a planned phase 3 trial that should be opening. So you only need one, basically first line therapy in combination with FOLFOX versus a standard of care. So MOUNTAINEER 3. So this should be open if I'm correct. And that, I believe, I do have one slide, which is something that's important regarding ESMO, but regarding HER2, are there questions?
I don't see any questions. So we also have Dr. Strickler gave a presentation about the MOUNTAINEER, and that's on Colontown University for people who are interested. And then, so Julie has a question. At ASCO, IMPROVE trial showed longer disease control on intermittent FOLFIRI plus Bev versus continuous. But there was a caveat regarding how study looked at while on treatment. How does that affect how we should interpret the result?
Yeah, I'm going to let Dr. Smitha, because she commented, she was the, she discussed this at ASCO.
Thank you, Kathy. That was actually like chemo with panitumumab. So it was with EGFR antibody, continuous versus intermittent, and very novel design, because they allowed patients who were randomized to the intermittent treatment to be off treatment, have scans every 2 months. When the tumor is growing, go back on treatment, but they didn't consider them as having failure of treatment when the disease progressed, because of course you're going to expect that the disease is going to grow during the couple of months or more off treatment. But they looked at when did this chemo regimen with the panitumumab actually become ineffective. So when they were on treatment, when did the tumor grow? So it was a novel endpoint. I hadn't seen that before. And they found that on average, it was 20 months before the regimen became ineffective when you do the intermittent treatment, but it was 13 months with continuous treatment. And they showed that patients had about like 7 months off of treatment with that approach. So, you know, they saved so much toxicity and time and financial toxicity. But we need to see some more data to see, like, did patients go on to second line therapy equally in both arms? You know, the last thing we'd want is somebody became too sick to go on to the next line of therapy. But, you know, it's from what we heard from the investigators, it didn't seem to be the case. So that looks very interesting. And, you know, I do give patients treatment breaks.
So I know we only have a couple more minutes. I wanted to know, obviously this is the big press release. This is, and in full disclosure, I'm the senior investigator that helped create and write this trial with Dr. Dasari at MD Anderson. So it was our last collaboration together. I'm very proud to be his mentor. So I wanted to let you guys know that there's a positive press release for this drug, Fruquintinib. Basically it was evaluated in a 2-to-1 fashion for individuals that had failed all lines of therapy, and we didn't want to exclude any patient. We wanted to give all patients opportunities to enroll to the clinical trial. So we did allow prior Lonsurf or prior regorafenib or failure or progression of disease to either Lonsurf or regorafenib. This is an international study. It is a standard of care already in China. This study was specifically written for approval for the FDA and EMA. Primary endpoint is overall survival. And our hazard ratio with 90% power that we're hoping to achieve was 0.73. And basically, I can tell you that we announced our press release I should mention, Fruquintinib is an oral agent that specifically blocks receptors 1, 2, and 3. So Bevacizumab blocks VEGF-A. This specifically blocks part of the VEGF pathway, but receptors 1, 2, and 3. And it's an oral agent. And so obviously that provides another opportunity for patients. And I can just tell you that we not only met our primary endpoint, which is actually mentioned in the press release for overall survival, but we also met our primary endpoint. Secondary endpoint for progression-free survival. And I can't tell you any more because we will be discussing it shortly.
Yeah, that's what, like, we saw the press release and it was interesting that there was no information in it. So we'll wait for ESMO then.
Because otherwise I'll get shot and I'll never be able to like present ever again or serve as an investigator for the rest of my life. So, you know, all for embargo. So
congratulations, Kathy.
I'm so excited. You have no idea.
Yeah. So we can go through the questions and see if there's something that we missed. We have a couple of minutes. Well, we have 1 minute actually.
Sorry. Yeah, somebody mentioned about good KRAS studies. I would just highly encourage you. There's a phase 3 trial with sotorasib. There's also a phase 3 trial with adagrasib. I can't even say them correctly. And then there's a phase 1/2 with Eli Lilly's KRAS agent as well. So there are ongoing trials for G12C, for the other G12D and other RAS mutations. There are some pan-RAS trials, but they're all very early in phase 1 development. But I know we're opening one up soon. I'm sure Smitha has some as well.
Yeah, like hydroxychloroquine, ulicertinib for RAS and MAP kinase mutations, like they're more likely to use autophagy to survive. So that's the rationale.
It's like a BMD trial. Is it Biomed Valley?
Yes, exactly. Yeah.
Is there any testing available for MSS stables to see if immunotherapy trials might be more helpful? I think that's a great question. I know there's a lot of interest in TMB. And we would just say that if you have the POL-E mutation by chance, that would be great, although it's less than 1% of patients. But TMB, the FDA approval, unfortunately, that study didn't include any colorectal cancer patients. I don't know if anybody knows that. So
Yeah, so
What about immunoscore? Like you had mentioned that with niche, they didn't see anything, but do you think that is something that's available in the US? And
it needs to be studied because immunoscore in so many studies is prognostic, but really it hasn't been proven to be predictive of response to chemo or immunotherapy. So, immunotherapy for MSS patients is still, investigational. I think we need more studies of in the neoadjuvant setting. But I wouldn't use it off trial at this point.
yeah, and then Laurie has a question about all the different IO plus TKI combinations. And, from what you've seen, do you suggest something versus the other? Like, what would be the rationale for that?
Oh, the AGENIS trial. So in full disclosure, I'm going to be an investigator on that trial. It was the hot topic of GI ESMO. So botensilimab is like a new CTLA-4 agent that appears to have small phase 2. Please keep that in mind. In combination with IO therapy, appears to have activity of, was it 24%, if I'm correct, in MSI stable patients. But if you took out the liver metastatic patients and only focused on the non-liver metastatic patients, the response rate went up to 49%. So it's going to be opening. We are one site opening. I'm sure Smitha, did you?
We are excited to open it too.
Oh, I set her up to meet them, so I'm so happy.
Thank you, Kathy.
So I'm so glad. Yeah, so we'll both be opening that trial for non-liver metastatic phase 2.
Yeah,
and then
go ahead. Sorry.
It's a great question because I don't know which one is better. Like why some TKIs are effective and some aren't. Why the Camilla trial, I think they had results with liver metastases, but the results were so much better in the RAS wild type, which I don't think has been replicated in other studies. So lots to learn here.
Can I just say something real quick? And thank you so much for inviting us. Dr. Krishnamurthi and I have been best friends, long-standing, 2000, oh my God, 2000? Something like
2002, we met at
2002.
the Yale workshop.
So we are delighted to work together to speak to Colontown, and I can only speak for myself. Thank you, Manju, for inviting us.
Thank you, Manju, and everyone for joining. We just love having this discussion.
Yeah, maybe I'll send you some, there are more questions. I can send you some emails and see if you can answer because we are actually running out of time. And thank you both for joining this. And this is my first time doing something like this. And I think that there is a lot of value in having you guys, discuss.
Oh, thank you. Great questions. Just honestly, fantastic questions.
Okay, thank you so much. And I'll edit it and post the video on Colontown University. So
wonderful.
Thank you all for joining.
Thank you.
Take care.
Everyone.
Bye.